1. First, we're going to have the invocation by Counselor Harley Buzzard. Please stand.
Okay, please stand. Dear Heavenly Father, as we gather here today at the Cherokee Nation to conduct business for our Cherokee people, we ask that you give us the strength and the wisdom to make the best decision for our government, for our tribal leaders and the leaders of the United States. We ask you for your blessings for our services, for our people that are in the armed services, for our veterans. And we ask all of this in Christ's name. Amen.
Amen. Thank you. Ms. Shelley, will you call the roll, please?
Yes, ma'am. Janelle Fulbright.
Present.
Dick Lake.
Here.
Jack Baker.
Here.
Harley Buzzard.
Here.
Joe Bird.
Honey.
Julia Coates.
Here.
Jody Fishinghawk.
Here.
Don Garvin. Hannah Glory Jordan.
Present.
Frankie Hargis.
Present.
Lee Keener.
Honey.
Curtis Snell.
Here.
Janice Taylor. David Thornton. David Walkenstick. Kara Cowan Watts. We do have a quorum.
Thank you. I assume everyone's had time to look over the minutes of our last meeting, and I'll entertain a motion that they be approved.
Motion to approve.
Motion and second to approve. All in favor, let them be known by saying aye.
Aye.
Okay, the minutes are approved. Next is the Claremore Hospital Service Unit.
Madam Chairman, I wonder if we could ask to amend the agenda
Yes.
before we get into reports. Make a motion to amend the agenda for approving the contract for contract health.
Second.
All in favor?
Aye.
Aye. Okay. We'll add this to the agenda. Claremore Indian Hospital.
Good afternoon.
Good afternoon.
Well, I think my report is in your packet. You see outpatient visits are down about 4%. Revenues for the total year for 2013 dropped. They were down just over 4% from 2012. New services, we have an agreement with the OSU Medical Center in Tulsa. The OSU cardiology van comes to the hospital twice a month and does cardiology testing. I found out today that we're also getting a chiropractic service 1 day a week on a trial basis for 6 months. There was a request last time, I think Council President, you asked for on our contract health numbers there to have that broken out by on the funded and denied and deferred by Cherokees. Staff's looking at a way they tried to find a way to do it automated, and they couldn't figure that out. We'll have it, we have to count it by hand. I'll have it for you next month. Okay. I apologize for not getting them here. Any questions?
Anyone have any questions for Mr. Valiers? Counselor Buzzard.
And just, George has answered part of the question I was asking last month. And I guess with this resolution that's being brought up today, George, it brings another question. That I would like to see that for county, if you can break it down that far. This resolution, it says Craig and Rogers in North Tulsa County. Well, I would further like to see those numbers for, and I guess I would just say the J Clinic for that.
Yeah, White Jan.
It's Delaware County.
Yeah, Delaware County. I'll probably have more discussion about this when we get into this resolution about that, but I would like to see those numbers. I think that's important to see before I could make a determination about this resolution that we got before us today. So I request those numbers also.
Councilman
Thank
Kennedy?
you.
Thank you, Madam Chair. My question along the same lines, you've been privy to this contact before today?
No.
Okay. And I haven't either. I don't know who all has been consulted, but I'm just curious as why the other counties are not on there. That you can't answer that, but you're going to stick around for discussion?
Yes, sir, I'll be here.
Okay. Thank you, Madam Chair.
Yes. Counselor Fishenhawk?
Yeah, can you go over to page 22 in our book? Hopefully you have, do you have our book?
No.
You want mine? It's probably for you and Brett Gray both. I mean Brett Gray, Brett Hayes. I'll look off time. We'd asked a bunch of questions about that. No. We asked a bunch of questions about that last month. It's a
Okay.
contract deal.
Okay, and what is your question now?
Well, we had a bunch of questions about it last month. I can go to the minutes. About 6 or 7 of us did. I requested a year-to-date chart for deferred patients. I requested classification for Ms. oh, that's something else. Some other counselors requested, when you all have the pending, we wanted it broke down to see how many pending. That was the year-to-date we was asking for. So we could tell how many pending actually got through the system and got served versus denied again.
Now, this isn't ours. I can, this is for Cherokee Nation.
Oh, let me find yours.
Okay.
Yours is in there somewhere. Go ahead and flip through it. What? Page what?
Of the first.
That's where it's recorded, Council Commissioner.
Oh, it's on page 6, isn't it?
Yes, ma'am, those are our CHS.
Okay. Like these deferred, 565 cases,
Yes, ma'am.
how many of them, last month, I can't remember what the number is, that's when we asked you about the year-to-date chart. How many of them deferred gets approved? We asked you that last month to start compiling it.
If they've been deferred, they won't get approved.
Deferreds will not get approved.
Because we expend every bit of our allotted money up here on the funded cases. That deferred is kind of a misnomer. I think that letter has kind of, I'm probably speaking out of turn here, but has probably outlived its usefulness as far as we're down on our street level. Now, for statistical purposes for the agency, I understand that the deferred, they want us to collect that information and send back up to the headquarters level. But for all practical purposes, down on our level here, deferred and denied would be the same thing. A denied case is for some service that has already happened. You've already been to the emergency room, or you've already been to that provider and received the service. The deferred is for something that hasn't taken place yet that you're asking to be sent to.
So really, it's 627 denied.
The what?
So really, it'd be 627 denied.
Yes.
He said the deferred never gets approved. And that's what he calls mine. Does Cherokee Nation do anything with the deferred, with our 5%?
Yeah, anything that comes up denied or deferred in our system is Brett looks at. I'm getting ready to talk with Brett. I'm getting ready to speak to Brett here.
I think Brett's here.
You want to point?
That's the ones, the deferred and denied that we got back through our system to the 5%.
Okay, how do they run percentage-wise of getting approved, Brett?
Pretty high, I mean, 90%, over 90. I know you guys have asked about how to,
90%.
the data, and we've got some data pulling problems, we just haven't been able to kind of, just because it's get down to hand count to the point of that.
Were you gonna have that next month?
We try to, yeah.
Okay. Because I'd like to look at them from month to month to see how many of them are getting approved, even though they're getting denied. Up there, they're coming down here and getting approved.
Right, and those are the ones in our 23. So 20. That's in the 22, 23.
They're added in them numbers?
Yes, 22. Those are the.
Can you get me the hard numbers so I'll know what the percentages are next month?
Yeah.
Okay.
And of the ones Georgia sees, about, shortly about 30. The others are the results south of Admiral, or live in a number of places that aren't in our area, or they're not Cherokee.
Okay.
Yes, Councilor Buzzer?
And just to follow up on Councilor Fisher Hawks' question, I don't understand this. We had 565 deferred, 62 denials, but if you look on page 22, we only seeing 5 denied. Is that, am I
That's
not-
Georgia's numbers. Georgia's numbers are all for all of Claremore Indian Hospital, and the ones we route through our system are only the eligible. So, about a, and this is kind of simplistic, but about a third live out of area, another third are not Cherokee, and a third are eligible. So that's why his numbers don't sync to ours.
So is that not what you're saying too, George?
Yes, sir.
Okay. Okay, that's what's not showing. Okay. Okay, thanks.
I don't think we'll have any other questions, so thank you for that report. It's very good. Next, we'll hear from Ms. Connie Davis, Cherokee Nation Health Services.
Good afternoon.
Good afternoon to you, too. And welcome.
I wanted to provide a brief update on the Affordable Care Act and how it's affecting Cherokee Nation and kind of what we're doing. We're communicating with all of our clinics and hospital administrators, the MIRs, and the patient benefit coordinators. We're addressing patient questions and directing citizens to their prospective county navigators. They're the experts. They have had the proper training by CMS in how to enroll and navigate, literally, the Affordable Care Act and get enrolled in insurance. The reason we're not navigators is if we take this training and become a navigator, then we have to be accessible to the entire public, not exclusively to our patient population. We can, however, become trained like to a certain level and be given what they call a unique identifier and basically do the same thing but not have to be responsive to the entire public. It is as complicated as it sounds. But we're taking a lot of calls. I probably get 4 to 5 emails a day all over the country looking, for how do I validate that I'm a member of the tribe so I don't have to enroll in insurance. We are encouraging everyone to make an application for insurance because many times we're finding that patients are eligible for benefits that they weren't aware that they were eligible for. And, there may be a catastrophic event that would not be covered by contract health. And of course, if they have a third-party payer source, it'll help our clinics run more effectively. So we're supposed to get our unique identifier, I think, on the 29th and become a little more active in getting our own group enrolled if they choose to be enrolled in insurance. I reported last month on some awards that our clinics received, and once again, we've received several awards on our government's Performance Rating Act. For controlling high blood pressure for a small facility, Nowata received an award. Bartlesville also, and Salina. For prenatal HIV testing, Veneta. Depression screening, Veneta. Fetal alcohol syndrome prevention, Three Rivers Health Center. Childhood immunizations, Redbird Smith and Sam Hyder and Veneta. Dental access, Three Rivers, Salina and Veneta. Retinopathy screening, Salina. Demonstrated excellent controlled blood pressures, Three Rivers, Bartlesville, and Salina. Good glycemic control, Three Rivers and Bartlesville. And reduction in poor blood sugar controls, Three Rivers and Bartlesville. So those medical directors, those clinics should be commended for a job well done. Those are great honors, and that represents how well our patient population is being taken care of. On the expansion, we're going over equipment reviews for the clinics. We had our hospital kickoff meeting on October 8th and 9th, and those are all going as planned. It's very busy, meetings about expansion daily sometimes. We transported 160 patients in the month of August for a total of 8,866 miles, and I just want to keep you updated on the number of patients and how busy those drivers are. Hastings had 418 surgical cases, which is another new record for that group. The left without being seen was 7.4%. Our goal is still 3%. I think when I get to do the report for October, you're going to see a marked improvement in that left without being seen rate. Cherokee Elder Care, or PACE, has 124 patients. November marks the Diabetes Awareness Month. We have several events that have taken place. Step Out and Walk was held on October 12th to raise money for the American Diabetes Association. Hastings Hospital, along with the health clinics and Cherokee Nation businesses, raised a grand total of $33,116 for the American Diabetes Association. And on November the 4th, Chief Baker will be signing a proclamation to declare November as Cherokee Nation Diabetes Awareness Month. And our diabetes program has put together awareness walks at all the health centers and a 5K run in Tahlequah. And we're just trying to get not only the employees, but the entire community involved as well. This past Friday, Counselor Garvin notified us. I'm not sure how we were going to find out if he wasn't notified, but Cherokee Nation was honored to be the recipient of the Edward P. Loveland Memorial Award that's given out by the American College of Physicians. This is a national award. And so we were recognized at their chapter meeting in Oklahoma City this past Friday. I'm so glad you told us, because they had the nicest write-up about Cherokee Nation. And I'm going to pass this around so that you can see what I got to send up there and listen to them say about our health centers. It was quite an honor to represent our health facilities. And that concludes my report.
Okay, we have Councilor Dick White.
Thank you, Madam Chair. What I call the one chart, or the information technology software packages, have
The electronic health record, yes.
you gone further with that?
We have. We're having meetings essentially now, trying to figure out how we're going to pay for it.
You want to tell us now how much it is, so we pass that up?
It depends on how we finance it, to be honest. And so we're working with the treasurer's office, trying to find out, because of course if you do long-term financing, it's going to cost more. But we want to make a decision that we can afford and get the product that we need.
And this thing is supposed to do everything, even set up and bark, I think, I hope.
Yes.
So you get it to do everything you need to do. The Camden group,
They are the group that the treasurer's office, where we selected for the feasibility study on the hospital expansion.
hospital.
Yes.
and the, I didn't see a report for no water in here. It may be in here, but I missed it, I guess.
In the clinic report,
Yeah.
I would have to go back and check.
You could-
I read it when it comes out, and that's 3 weeks ago.
I
Well,
know.
more than that now.
You could each have somebody email it to me, I
Yes,
appreciate it.
of course. You're welcome.
Thank you.
Counselor Garvin.
Yes, thank you. I just want to say congratulations on this honor. I've been working with this doctor for some time, and he kept me informed, and we need to have someone to receive this honor, and I think it's going to be in Orlando in April or May or sometime.
Yes, I didn't finish reading that part of my report, but we'll get the official award, whatever trophy or recognition, at their spring conference in Orlando. I believe it's April 8th through the 10th. Don't hold me to those dates, but it's quite an honor.
I pass the word on down to the ones that really earned it.
Oh, absolutely,
Okay.
absolutely.
Thank you, Madam Chair.
Counselor Buzzard.
Yes, Connie, I just wanted to bring to your attention, and maybe I'm reading this chart wrong, and let me just try to explain it. When I looked at, maybe I'm reading it wrong. I just compared the clinic in Jay with the clinic in Salina. They're both in my district, one in Jay and Salina, it's in my district, but it's on a collection of insurance billing. And the numbers I come up with, and you can have Amy check this out for me, but what I'm seeing is Salina has seen about well over 9,000 patients for 1 month. Jay is also, they saw well over 8,000 patients. And the difference in patients is around $1,300, $1,350 a patient per month. The difference I'm seeing in the third-party collections, Salina has, this is right here. The difference in patients was like 1,300 patients difference between the two clinics. Salina had collected it's in the patient's billing is what I'm not getting here. They had received all the money from the third-party billing, and Jay is out about $1 million there. They hadn't collected, and they still almost the same amount of patients. So if you could look at those numbers, I would appreciate it. I'm not sure I'm looking at my numbers right.
And you may be interpreting it correctly. That's why we've got this Access to Health group coming in,
Okay.
and they're working every day with our clinics and our finance department, because that is an area we know we need to improve, is how we bill and collect. And the other thing, just speculating, you might find that there's more people with a payer source in those areas, and in one area versus another.
And I considered that. Yeah.
So, but we can look at that further and
Appreciate
try
you
to
looking
follow
at it,
up.
because it looked to me like there was almost $1 million of difference in collections for the amount of patients that we've seen. And so that really threw
It's a
a
lot
red
of money.
flag up, because that's a lot of money that we may be missing out on.
You bet.
That we should be collecting on. And I was looking at the, in Delaware County, it's, and I thought, well, maybe they don't have much insurance, but still you have, of course, you have the casino over at West Palm Springs, county courthouse, county government, got the schools, the Simmons plant, they all have insurance for their employees. So the flag was raised that we're missing a lot of collections on third party.
Absolutely.
So I appreciate you take a look at that. The other thing I had, and I just wanted to, I looked at the satisfaction charts for each clinic, and I noticed they ran all the way from 66% satisfaction to 93% satisfaction. And what are we finding out, the ones that weren't satisfied, what are we finding out that people aren't satisfied about?
Oh.
I'm curious. And I'm sure there's probably a number of things.
Oh, yeah, we could talk from here to next week
Is that
about
right?
why they're not satisfied. You know, a lot of it's access, and I think just bringing our healthcare system and how you can get in up to date. You know, if you go to a private sector now, a lot of people can book their appointments online, and I know there's some council members in our room right now who've tried to get appointments into clinics, and rather than accommodating the patient, the clinics are more focused on just whenever there's a slot, and we need to become more accommodating and treat our patients more like the customers that they are. We have began training on customer service with CMB. Brian Hale started it at the hospital. We hope to take that throughout the entire health system, because a lot of times we just forget these patients are our customers. And usually if you're at a doctor's office, you don't want to be there. There's something wrong. You're worried and you're stressed, and we forget to be nice about that and sensitive to those kinds of things.
Well, I'm really happy to share that with David, because I really felt like we needed that, and to hear you say that is really pleasing to hear that you're doing that and working on those problems. And I have seen some improvements. I know you've probably heard from me a time or two, and I have seen some improvements on it. So for you to say that is really encouraging to hear that you're going to do the training, because I know I've worked here for years, and sometimes we tend to forget who we work for, why we're getting a paycheck and why you're there. So that's good. I appreciate what you're saying. Thank you.
Appreciate the
Madam Chair.
support.
Anyone else have any questions or comments? Well, I do. First off, I want to talk to you and address this to Dr. Montgomery too, to think about. I have suggested this before. I think we need a cancer care coordinator or a navigator at each clinic. Reason being, a lot of our people are really, really sick, and they're going to OU, Medical Center, Tulsa, different cancer places, some of them even in Texas, and it's kind of up to the family to make sure that the clinic that they're going to faxes in the request, and then maybe they just tell their provider at the clinic and they think it's being taken care of and nobody's following through, and then when they get ready to go to their treatment, they don't have the referral in hand because it got lost in the shuffle. And like OU, they claim to have an Indian navigator up there to help everybody, but they don't do a very good job of it, I'll put it that way. And at one time in Redbird, we had a cancer care coordinator for 6 months. It was a pilot program, and I heard they did away with it because she wasn't busy enough. But I was familiar with the job she did. It was excellent. And I would like for us to designate somebody, even part-time, one of the case managers or one of the top nurses or someone, to help folks out with that, because it's a real problem. And that's something I'd like to see addressed.
I will follow up on that and see which clinics do in fact have those. I thought we had one at Redbird, because this isn't the first time you've asked me that, but I'll follow up and validate that by email.
Well, they don't. I can assure you that they don't. And I just wonder if they do it other places. And I'd also like to know how we're progressing along inch by inch on jumping through the loops and hoops for Medicare and Medicaid approval for our dialysis center at Redbird. Are we getting a little bit closer?
I haven't heard an update, to be quite honest. I will make a call after this meeting and try to let you know before the end of the day.
Well, the last timeline that I saw, it appeared to me it was going to take another 8 or 9 months to actually, to full-fledged start taking patients that did not have a private payer insurance. And I just kind of wanted a little progress report on what was
Let me
going on down
clarify.
there.
I thought they had already been surveyed, but evidently not. I will let you know before the end of the day.
Okay. And also, I would like a little update from Mr. Sanders back there about how our 90-day prescription policy is.
He's glad you asked.
Very dear to my heart, so I would like to have a little update.
Okay. I know that I've just got a few numbers here that between October 1st and the 18th, we filled a little over 1,300 prescriptions for the extended day supply. So
Right.
things are moving along well. I really don't have any good information on billing yet. We billed some. I think we billed around 480 of those claims, and we got paid on around 260 or so. But I won't really have dollar figures or values probably for a couple of months yet. That will be meaningful.
Okay. Counselor Buzzard?
Just to follow up on that, are we losing money by going to the 90-day prescription? Now, I've heard different things on it. Is that the report that you're going to be generating for us?
Yes, we'll be able to show you some numbers. And yeah, we're going to lose some money by going to 90 days. If we take the claims that we're paid now at 90 days and we divide those by 3, which is how I'm going to determine just quickly, what we're looking at, that will be the amount paid per claim. And in the past, that was around $9.80, $10 for most of our claims that we sent in. And we're probably going to be looking at around $4.60 to $4.80 per claim. So that's just rough estimates. Hopefully it's going to be better because we put a lot of effort into trying to improve the relations or contracts, agreements with our insurance companies to get paid for 90 days.
So you said between 480, 450, is that per month? Is that what you're saying?
No, per claim. If you took each prescription and assigned it a dollar value based.
So if you ran them for 3 prescriptions for the 3 months, so you're talking about $12 or something like that?
Correct. Right. So, let's just take, for instance, that previously we received $10 per prescription for a 30-day supply, and we submit these and we receive $20 for a 90-day supply. Then if we divide that by 3, then that gives us a close estimate to what we had for a 30-day supply.
It'd be interesting to see what those numbers come out to be. I'd be interested to see that too.
Yeah, we will report the revenue generation,
Okay,
I think,
sure.
each cycle as well.
Thank you.
All right, thank you.
You're welcome.
Anyone else have anything? Okay, we'll move on down to our old business. We've got discussion and possible action on the 5% set aside. Counselor Lay?
Yes, ma'am, I'd like to make a motion to table for 1 month.
Table for 1 month.
I'll second.
All in favor?
Aye.
Okay, we'll table this for a month. On our new business, Counselor Lay, this is a resolution approving a compact for contract health services for Craig County and Cherokees only in Rogers and North Tulsa County.
Yes, ma'am, thank you. And I believe, if I could just have a moment,
Yes.
Madam Chair. Beginning last minute.
I'm going to hand out a little bit more information while they're doing that for everyone to see, and it'll partially answer some of your questions, Counselor Buzzard, about some of the numbers. There's 1 page. Pass it around. Wait till everyone gets it, and then
Madam Chairman, I'd like to make a motion to bring this forward to the council, a resolution approving the contract health service for Craig County and Cherokee's only in Rogers and North Tulsa with an amendment here, if I could, under the 4th whereas, where it says approval of the compact needs to be improved, scratch that. And it should say approval to amend the current compact.
Okay, approval to amend,
The current compact.
approval to amend the current contract.
And under be it resolved where it says hereby approves after Cherokee Nation, you say negotiating an amendment to the,
Be it resolved by the Cherokee Nation.
okay, after it says Cherokee Nation, scratch hereby approves the, and install negotiating an amendment to the.
Shouldn't you just say amends? Because when you negotiate, you should scratch negotiate.
And Councilman Baker and I are looking at this a little bit. I think we might just say amend the compact rather than the other.
To include.
That's essentially what we need to do. We're keeping our existing compact, and one of the pieces of paper you have is the language in the compact as it currently reads for CHS and for facilities, the two sections that might need to be amended. CHS section will need to be amended to show that we're adding counties and what we're adding them for. The facilities one won't need to be changed to say anything because we made that general enough with Indian Health Service when we negotiated the original compact that it allows us to expand to any facility really and provide service without having to go back to Indian Health Service for approval.
And I make that motion, and so we can.
Okay, you made the motion, and who seconded it?
I did.
Second. Councilor Bakershaw? Yes.
Could we just read the changes one more time so I make sure that I understand where they went? Maybe,
If you want me to do that.
yes, if you would, do.
Okay, approval to, sorry, on this 1, 2, 3, fourth whereas, at the end of the first sentence, scratch approval of the compact needs to be approved.
And we're
Correct.
changing it to,
Approval to amend the current compact. And under be it resolved after the second sentence where after Cherokee Nation, scratch hereby approve thee and change it.
Hereby amends. Amends the compact.
Hereby amends.
To add. Great County. And all those users.
Change that to hereby amends. And over at the end of the sentence, after services, to add, scratch the FOR, scratch the full.
and then continues on as is?
Yes.
Okay, thank you.
Councilor Fisher-Hawk?
Yeah, why does it have all eligible users in Craig County, and then it has just Cherokees in Rogers and Tulsa?
I can answer that for you. This page that we just handed out, you take a look at the top two tables. Whenever we sat down to negotiate with the Indian Health Service, and it was a preliminary negotiation, and Mr. Vallier, to answer your question, counselors, about had Mr. Vallier heard about it. When we contacted Indian Health Service, they asked us to come to the area office. They had their contract health service director there, the area director, the head of self-governance, and some statistical people that worked on population and financial numbers. And so those are the people that we sat down and talked with. And we asked them, we gave them the information that we would like, and we told them we wanted a breakdown of the users there on that first column in the top two tables. So we wanted things broken out by Cherokee users. The CIH Service Unit Indigenous are the other tribes within the Claremore Indian Health Service Service Unit jurisdictional area. There are 17 tribes in that. So those numbers would be any of those 17 members from any of those 17 other tribes in the service area. Then that next line that says non-indigenous is any other tribe in the nation of an individual that might live in that geographic catchment area.
That's other than the 17.
Other than those 17. So we asked to see that by Craig County, Rogers County, and North Tulsa. And then that second table, we asked the area to plug in the dollar amount that would go with each of those numbers if we assumed CHS authority, outpatient CHS authority and operation for those same categories. So the top one is numbers of people that are currently registered in the IHS database that are being used in those counties, that are users of services in those counties. The next table is the numbers of dollars. So what we're proposing then is for Craig County, you can take a look and see that 2,857 people out of the 3,193 are Cherokee. and to make it easy for all the patients that seek services there. And we do this in a number of our other facilities. We don't just do CHS for Cherokees only. We are suggesting that we assume operation for all Indians in that particular county. So, and that number right now of other than Cherokee is about 336. So, and that just makes it easy for our physicians and other providers, and it makes it easy for the patients to know if I go to Veneta facility and I need to be an outpatient CHS sort of patient, they'll take care of me right there at Veneta. And we won't have to say, oh, you're not Cherokee, you need to go, to Claremore. Now, it's different when we get down to North Tulsa and Rogers. When you take a look at the numbers, they're much larger. They're almost 12 and 8's 20, almost 21,000 people that we would be taking on for a total of $3.1 million. And we are suggesting that we do not take on the additional users that fall into those other two categories, the Claremore Indian Service Unit Indigenous Tribes, nor the non-Indigenous tribes to that service unit. And we believe those really are the questions that you all have been asking us about a lot. That'll make all Cherokees in essentially almost all the areas that we can take over from Indian Health Service and assume operations under our control for outpatient services. Now, the inpatient services, the patients will still need to go to Claremore in that particular area. We only right now have inpatient services for the 3 counties that are around the Tahlequah Service Unit. Correct, Brett?
The only problem I have with it is this money's Gen Fund dollars. The 5% is Gen Fund dollars, and we're going to spend it on non-tribal members. In the Craig part.
And if you take a look at that per capita figure down there, what we're getting from the IHS, if all these numbers remain constant when we do a final discussion with them, if you all approve, we're getting a per cap number of about $148 per patient. When we talked with them a number of years ago and looked at this, that number was much lower, and it was much lower because over the last couple of years in the Obama administration, they have put a significant amount of money into contract health services. In the methodology that the area is using to distribute the funds makes it such that the per capita amount that we would receive here is greater than our current per capita amount that we're spending. And because of that, we think this is a good thing, that it's not going to hurt our contract health service program by lowering, I don't know if I want to go on the record saying this, but we don't think it's going to lower our level of services across the board to anyone just by taking on outpatient only. And the fact that we do have the 5% dividend funds available, it makes us even more comfortable in saying that. Because the per capita numbers that we're using right now, are lower. We think this, and notwithstanding the equity issue, being able to say to all Cherokee citizens that you're being treated the same way, at least for outpatient. And whenever we discussed it with our CHS program, it is between 80 and 90% of the services that we refer out are outpatient type services. Inpatient services are relatively rare, and those are still going to have to go to Claremore, but the bulk of the patients that we would see now are going to come under our CHS if we were to take the action that you're discussing today.
My only sticking point is still that these are Gen Fund dollars. And I realize that when you take the number of people you're talking about, your indigenous and non-indigenous, you multiply it by the 150 almost, you're almost breaking even. But how am I going to sell it to people that we're using Gen Fund dollars to take care of other tribes?
I guess it depends how you look at it. We're not asking to take Gen Fund dollars to do that. The Gen Fund will still go to Cherokee only.
In Craig County?
Yes.
These are Indian Health dollars.
Yes, these are
Compact dollars.
These are new dollars we would get from Indian Health Service if we assume operation. None of these are monies we don't even have yet.
So really, if you take the 335 and multiply it by the 148.77, you're going to get 49,800,
Yes.
which you're looking at right at 50,000 for the proposed assumption. So you're talking about a break-even point.
We think it's at a break-even point, and the only thing that could conceivably, right now, screw things up, is at the end of the year, when Indian Health Service runs out of the catastrophic health emergency funds they have, and we might have to pay for like an incredibly high-cost case, in the very last month of the year. But that could happen to us right now. I mean, it could happen under our current operations. I mean, every tribe sort of faces that risk. And I guess, anytime you take on additional CHS, you're taking on a little additional risk because you don't know what will really happen when you start referring people outside the system. But if I didn't, and Brett, it's the same way I think, and Connie and Dr. Montgomery, if we didn't feel comfortable about, saying that this was acceptable risk, we would tell you right now that we don't feel comfortable about it. But after we've looked at everything, we feel like it's an acceptable sort of risk to take.
But we're really not treating all of the outpatient Cherokees the same, because you're still leaving out Wagner, McIntosh, and Ottawa. So we really can't make that statement still
And
yet.
Delaware. And
No,
May.
Delaware we're doing for outpatient.
Outpatient's what I was talking, yeah, outpatient. That's what I'm talking about. You're still leaving out them 3 for outpatient, so you really cannot say that you're treating them all fairly still.
And we did talk to the area about 2 of those areas.
Okay.
And they can't figure out a way yet to break the dollars up, like in Wagner.
Ottawa to save my life.
And
Well, there's
you want
not-
to say
I mean,
anything about Ottawa?
With Rogers and Craig, they're counties, so they're easy to determine. McIntosh, I'm still learning new things. I grew up there and I'm still learning things about McIntosh County. So it's going to take a lot more.
Where's McIntosh's? Where did they go?
They're 100% Creek Nation.
Creek Nation. Okay, how about Wagner?
Wagner's
Cherokee.
Park Creek, Park Claremont. Creek, George, correct me here. Creek is for the outpatient. No, Creek is inpatient. Claremont is outpatient. Wagner. Hey, got it.
That's how it's divided up? Okay. And then Ottawa's,
Ottawa's 100% Northeastern Tribal Health Center.
the one up there that we share with all the different tribes.
Right.
So we sort of have control, but we don't really run it that, they run it separately. But we're
I
part
can
of
go
that
up there and they
consortium.
just soon hang up on me as they would anybody when I have to mess with them. Okay, thank you.
So there's not really an easy way for us to take that, counselor, that particular one you're talking about. And we did ask the area if there's some way someday they could figure out how to get us a little piece of Wagner that's actually in our jurisdiction, in our tribal jurisdictional area. But right now they can't figure out a way to do it, and we haven't been able to propose a way to figure it out exactly either how to break that up. So we're taking, if we do this, we're taking almost all we could assume, unless we can figure out something for if the Miami Tribal Consortium or the Northeastern Tribal Consortium ever decides to turn loose of a little piece. I guess we could at some point propose that to them, but it would have to go to them. All the tribes would have to agree.
So this is as most as we can take over, except for the 3 exceptions that's still up in the air, and you're looking at it to break even, basically.
Yes, we think it will.
Short of somebody having just a huge case.
And we do very, very good at recovering. Right now, that threshold is once your CHS program spends $25,000, you can recover above that, and we do. And we're very aggressive about that. And it's only when they totally run out of money at the end of the year, if we have something that comes in, then your CHS program, it's their responsibility to take care of it. But Congress has added quite a bit to that pot of money in the last several years, too.
How good does Claremore do at outpatient? I have heard that they have a heck of a lot of referrals up there on stuff that we normally do inside at Hastings.
That very well may be the case. I don't know. And with Mr. Vallier here, I might leave that question to him.
How did you find that information out?
I mean, I guess I'm not quite sure of an easy way to do it. We could kind of sit down and look and try to propose a way to figure out what we provide in the way of inpatient or even well, not inpatient, but outpatient sorts of services in our facility that they don't, that have to be sent out. I mean, you haven't got the CT yet, right?
So that's one
Yes,
thing,
yes.
you know, we have,
We did have the CT,
oh, is it in now?
the MRI.
Oh, the MRI's not in. Well, then that's not good. That's not a good example. So I don't know, we'd have to just,
Now, we've historically not referred people.
Well, not Hastings, but I mean just other doctors outside the system. I have heard that several times from several doctors that's worked around in our different clinics and hospitals, that up at Claremore, they refer a lot of people out to do it, you know, they refer them to Tulsa to a specialist, or they would refer them here or there when they could be doing stuff inside,
No.
much like we do at Hastings.
No, in fact, on my report, right at the bottom, on the second page, at the bottom, it says category 2, I think is what it says. Those are all out of the number of, out of the 1,073 cases that went through last month, 102 of them were diverted back into the system, because that was something that we could do in-house.
But that was stuff doctors wrote to go out of house, and you all deflected them back into it.
Yes. People that
Maybe it's the training with the doctors you need to do, to get them to do more,
well,
instead of referring them out so much. I mean, my people down here, believe it or not, my constituents down here can tell me how contract services works better than I do. I will say, well, did you not go contract services? And they will tell me, do they do you all? No, it don't classify, they won't go there. And I'm really shocked down here at how well our constituents know whether to even ask. And I'm saying that's part of our reason that we don't have so many denials down here. Because like I said, they know better than I do. And I'm a council person. And that's what I'm wondering, do we just need to get some education up there with the doctors on what can be referred and what can be done inside?
they know what we don't do a lot of specialty.
Well, at least 3 of them a day is sending them out. There's at least 3 cases a day being sent out
Oh, yeah.
that they could be doing inside. Okay, thank you very much.
Speaker Jordan?
Yes, I just have a couple of questions. Did I understand, Chuck, you said that 3 counties already, I guess that being Cherokee, Adair, and Sequoia, already take care of these 2 areas that you're proposing that we add into Craig County?
Yes, and even more than that. When I was mentioning those, I said those are the ones we only have inpatient CHS coverage for. Every county, every other county, and all of our jurisdiction, and Brett, correct me if I'm wrong, we see all Indians. So all 3 of those categories we assumed for all of the areas around all of our clinics.
So for Craig County, you're not doing any different than what's already in the system?
For every other
And I think why that's
outpatient.
different is in the past, about the time we compacted, and this is prior to us, I've been here 9 years, so it was a while back. About the time we compacted in those northern counties for the outpatient, the Northeastern Tribal Health System compacted for Craig County, because they were, a lot of their users were from Craig. Well, between now and then, they retroceded that back to Indian Health Service.
Okay.
So that's why, I think if that would happen, we might have contacted them anyway. I mean, that's a reasonable assumption. So they gave it back about 4 years ago. So now it's been in kind of a limbo since then.
So this would make it the same for that facility in that county as it is for the rest of our jurisdictional area, except for this part we're getting ready to talk about, which is really in close to Claremore for just Cherokees only. All the rest of our facilities are, with the exception of the ones in those 3 counties around Hastings, are outpatient only and all eligible Indians in that catchment area.
Okay, now my second question. What do I tell my constituents when they cross the bridge to Taylor's Ferry and Bond, but they're still within the jurisdictional boundaries of Cherokee Nation? What do I tell them as to why we cannot include them?
Boy, I'm
thing I
trying to
tell
think
all
about something good that I would say if I was a counselor. It's basically the government bureaucracy has not yet figured out a way to break those funds out, such that the Cherokee Nation can assume control of them. The one thing that you all have done for them, though, is the fact that they are going through Claremore. And then if they go through Claremore and get denied, then they show up in our 5% pool.
Okay.
So, and that is for Cherokee citizens only, so.
Is there the possibility that we can continue working on that little area across the lake and Ottawa County and some of these other little pockets that we've not been able to pick up? Seems to me like there would be a way to separate them, or at least in the area that I represent, from Creek Nation and bring them over to our area. They certainly want to be there very badly.
We can look at that, yeah.
And
And Ottawa will need to talk with that consortium. The Wagner County, we just need to talk with area office and see between them and the creeks and us if we can figure out a way that's acceptable to break that money up.
I have a feeling that breaking it off from Creek Nation would be a very minor amount coming to us, but it makes an extreme amount of difference to the Cherokees that we have in that area. And I would ask you if you would bring us numbers next time, and if you would continue working towards that endeavor of bringing them into our area. Because the only thing that I ever hear anyone ask for when they cross the river is the health service part. I don't believe any Cherokee has approached me on any other item within the jurisdictional area of Wagner County other than, can you help me with contract health? And then we get boggled down with Creek Nation and service area, and we're failing our people in that little area.
We'll see what we can do. I mean, it's something we asked about when we were up there talking about all these other counties, and the area just did not have a good solution for it, but we said we wanted to talk about it in the future. We've not pressed them about that since that time, so
Well, I
we'll go back
commend you,
and
and I'm
ask.
certainly going to support this. I commend you. I commend Chief Baker, because I know you all have worked very hard to try to make this happen. And this is a great step, and it's a great day. If we can just go a little bit further, it'd be almost the perfect situation for us.
We'll see what we can do.
All right.
And if they can give us something quick and easy, we'll let you know. If it's going to take a protracted amount of time, we'll get this completed if you all pass it, and then it'll be a simple amendment to do to the compact once we figure out how to break it up.
Well, that really appears to be the #1 issue when you cross the river there.
I would agree with you, too.
Thank you very much.
Thank you.
Councilman Thornton, you're next.
Thank you. From what I understand here, what I'm looking at, Craig Rogers, North Tulsa, their total is going to come to $6.5 million. And that's going to be drawn down out of the Cherokee Health Services. It's federal money.
It's federal money, and it's about 3.6.
But down here at the bottom, you had 3.1 million, Rogers and North Tulsa.
Yep, that, and then you add that 475 right above it. That would be the total dollar amount we're talking about. And that comes from Indian Health Service, and it'll be put into our contract health service budget at that time.
I believe it has a 5.6 million up there with the totals of all.
That would be if we took,
Cherokee users enlisted.
yeah, that's, if we took everybody in all three of those counties, it would be 5.6 million.
It's really going to be 3.5 or something.
Yeah. We're opting at this point to not take anyone but Cherokee in those two large population areas.
And this is not taking on the 5% discretionary funding at all.
No, the only thing that'll happen is, theoretically, these people, actually all these people, since we aren't running these, theoretically all these people that are Cherokees in these areas have had access to that 5% dividend money, the way the act was passed. So they'll still have access to it if they're Cherokee and they get denied for some reason, but they shouldn't be getting denied now once they're in our system. The approval rate will go to a much higher level. It'll go up to between 90 and 95% for outpatient services. They shouldn't be getting denied. And if they're Cherokee and we happen to run out of Indian Health Service money, then we can use this 5% dividend funds on them.
Okay, on the contract health care on the 3.1.11.
Yes, sir.
Then we're not taking out the Adair, Cherokee, Delaware, Mays, Muskogee, Knollwater, Sequoia.
No, sir.
Counties,
What we'll do is
replacing it with what you have here.
we'll make an amendment we'll leave everything like that in there, and we'll make an amendment that says we'd like to add Craig County outpatient, all Indians, and North Tulsa and Rogers County, Cherokee only.
Sounds good to me.
So all we'll do is add those phrases into this particular wording. This is the wording out of our compact that will be amended.
Thank you, sir.
Anyone else have any questions before we vote? Oh, we got more questions. Okay, Counselor Buzzard.
Yeah, I think I understand it a little bit better now. The other thing that I do want to touch on, and you touched on some, is the people in southern Ottawa County. We have about 2,000 people up there that are Cherokees, and I understand there's about 80 to 85% used in a health service facility in Miami. And I'm glad to hear you say we're going to do some negotiation with it, because that's what I hear a lot. That IHS runs the facility, we get no help from the Cherokee Nation, but yet our clientele is about 80% Cherokee up there. So if we could pull those dollars back, it would probably help a bunch. But I don't know if you're ever going to be doing that up there.
Yeah, and
That's the touchy subject right there.
it probably is to take money from a tribal consortium like that, even though we're a part of it. You know,
I
the
know,
Cherokees
but-
are a part of it,
I know,
but it's
apparently
touchy.
we don't play a big role in it up there because
There's so many other tribes involved.
But I hear that a lot, you know, especially in northern Delaware County, that, we live in Ottawa County, it's called the river, actually, and that's where they use it, so, well, good luck, I'd like to see it do it, but I don't know.
That one will be harder than the Wagner situation.
Okay, thank you.
Counselor Keener.
Thank you, Madam Chair. When will this be rolled out and implemented?
By law, once we write a letter to the Indian Health Service and tell them what we're proposing, they have a maximum of 90 days to approve it or deny it. And if they deny it, it's usually because there's some technical problem and they will help you fix it. And they usually deny it much, much sooner than 90 days. They'll tell you what the problem is. The area office said because this is a relatively simple assumption, they think they can do it in much quicker than 90 days. And I guess what I would also tell the council, because of the situation the government's in, the numbers that I'm showing you here are not the actual numbers we'll get right now. The government has only approved a budget up until a certain date, till January, whenever. So we'll get that pro rata share of this amount. And as soon as and then since we did not do it on October 1, they'll reduce some pro rata amount, for however many months we didn't operate it that Claremore did. So the first year it'll be a partial funding of this dollar amount that I show you. But the day it starts, we should get the full remainder of the year's pro rata amount once Congress passes a full year budget. And then next year, we'll get those first few months that we did not operate it. That'll come into our budget. So in FY15, we'll have these full dollar amounts that are on this paper. And hopefully maybe more if Congress approves additional dollars.
That was my next question. Thanks for answering that.
It's kind of complicated this year.
Counselor Fisher.
I'm sorry.
Are you through?
I have a few more questions.
Oh, okay, go ahead.
Thank you. So I was going to ask, how will this affect the day-to-day operations with IHS and Cherokee Nation?
It's a good question. I'm glad you asked that because I hadn't mentioned it yet. What we're going to propose to the area, and this is one thing we did discuss briefly with George a month or two ago as we were starting to do this, is we're going to ask the Indian Health Service, since we're assuming so much of their operation, they're out of Claremore, if we get the additional staffing dollars that go along with that. In other words, do we get 2 or 3 staff that work in CHS that can now come to work for us? And if we do, those people will sit exactly in the same place. They'll be our employees, and they can either come over as federal IPA like we did at Hastings, or they can come to work as Cherokee Nation employees. But they'll just work there, and they'll take care of the Cherokee-only citizens that come in. If the area office says no, and we know Claremore is very, very strapped for space, in a worst-case scenario, what we might have to do are take 2, maybe 3 CHS clerks, put them in some other facility that Cherokee Nation owns in Claremore, and say, And then the CHS clerks at Claremore Indian Hospital, if they were referred out of there, they would say you need to go to this facility. But in reality, a lot of the outpatient referrals are coming from our own facilities anyway. So what we would say to our CHS clerks in Nowata, Bartlesville, Veneta, all those places that used to tell their outpatients, you got to go to Claremore. Now we just tell our clerks, you have the authority, at that location to approve and pay for it. It's not going to impact as many people on here as you think, because those people go to outpatient services in a lot of our places anyway. And so we're going to talk to the area about that. There might be some additional funding above and beyond this that we can get from IHS, and it would be staffing dollars, and we would most likely leave those people at Claremore to just see our patients as they're coming through. So that's kind of the impact on operations. Small number of Cherokees that are getting those referrals out of Claremore would come to us either there or somewhere else, and in our own facilities, this large number that are already being told to go to Claremore now just get approved at our facility, so it'll be much easier for them.
Do you know about how much the administration dollars would be?
Brent, and George might know. A couple of CHS clerk positions.
He hasn't brought up the administrative cost of $50 million on what might be associated with that amount of contract.
So unknown, but it's not going to be a huge amount, but it would certainly be enough to pay for the types of clerks we need.
And from about 1996, when we contacted the CHS, started doing here, we had staff working in Hastings up until 2008 when we contacted the health hospital. So we had people there, so we working together. So it'd be similar to that.
Similar model that we already have done and know how to do, and it's just working out with IHS, with George and area office, whether we can get and use some of their staff to do it, which would be converted to our staff, or whether we need to put staff in another location. And we'd love to put them in the Claremore Indian Hospital, and it'll all be a factor of space, come down to that.
They are space. I think one thing that might help us as we go forward, we do have some maps of the current jurisdiction. So if we could get updated maps showing us, the council and everyone, the citizens too, where they fit into this, that'd be real helpful.
I have to look at that map almost every week.
Yeah.
And I always look at it before I come to see you guys on this Monday.
Thank you, Dr. Graham.
Thank you.
Thanks, Madam Chair.
Thank you. Councilor Fishenhawk?
Dr. Graham, you done a wonderful job. I never would have thought I'd be voting on this. But you have backed up the numbers and showed me that it's not really, like I said, it's going to break even. And I know I argued with Bill John a couple of times about our contract health and our 5% when he was wanting to do what he did with it. And I was really expecting Lee to tell you thank you. Because I think what you're doing is wonderful for Rogers and Tulsa County and Craig County. The people up there, I'm sure, will be happy.
I think they will.
And if I was you all, I would get it out in the press as soon as possible, because this is good press.
Thank you.
Very much so.
Thanks.
Thank you.
Yes.
Thank you. Did I not say thank you? I'll say it again, though.
I always assume that from all of you. You don't have to say it every time.
I did say it. Thank you.
Even when you...
Councilor Knight?
Thank you, ma'am. And I want to say thank you, and thanks to you and your staff and Brett and the chief for letting you work on this. This is one of the most complicated, frustrating, emotional issues on the north end. Tina gets a few coming across the river. I get them right in my doorstep all the time. And Lee and Harley, Robin, Janice, and I and Kara, we face this stuff every day. We appreciate your work.
You guys are welcome. We had a lot of people working on it, and you all pushed us to continue to get it done, so thanks.
Thank you.
Couldn't do it without your approval, so thanks.
Dr. Graham, I want to say thank you, and we've got the brightest and best working for us, and I want to commend Councilor Lay for pushing this, but I can add to it, it's not only the councilors he named, that's not my district, and I have all kinds of people calling me, but I don't even know how they get a hold of me from Claremore, but they manage.
I'll give you your number.
She's chair of the health committee, right?
It is a very complicated system that the federal government has put us in, dating back to the 1950s. It's outdated, and you have worked a magician act here to try to bring it up to date and modernize it a little bit to help all these folks. We really appreciate you and all your health team and everybody that's worked on it.
Well, you all can
Thank you
take
very
credit
much.
for it as well, because like I said, it wouldn't have happened without your approval, so thank you.
Okay, I think we're about ready to vote here.
I've got,
One more thing?
we've got a little bit of a Scribner's.
Oh, a Scribner's error,
I'm gonna
okay.
turn this over to Councilman Baker. He's
All
good.
right, he'll straighten us out.
Okay. The last whereas, the whereas in order to provide outpatient contract health services, scratch most of the next line down to Fort Craig County and Cherokee's only in Rogers and North Tulsa County, scratch the end, and it says therefore, be it resolved by the Cherokee Nation that the Council of the Cherokee Nation hereby amends the compact to add outpatient contract health services for all eligible users in Craig County and outpatient contract health services for Cherokee eligible users only in Rogers and North Tulsa County. Wow, that's a lot of
Miss Shelley, you got all that? I'll get one for the Okay, all right. So any other comments here before we get ready to vote? Yes.
Does this need to go to
It
full
does need to
council
go to
tonight?
council tonight if we could, Madam Chair.
Okay. We want this to go to full council tonight, so,
Who made a motion?
who- you make a
I
motion?
make a motion for it to go to council tonight and to accept the changes that Councilman Baker's doing.
Okay. Okay, all in favor of that, let me know by saying aye.
Aye.
Okay, now we can vote on the main motion. And everybody that's in favor of passing this, let it be known by saying aye. Aye. Any opposed? It passes. And anybody else want to be added onto it as a sponsor? Does everybody want to be added? Okay. Thank you. Councilor Fisher-Hunt?
Oh, no, I
I
just
hear
read
you say you want to be added, okay.
I think everybody wants to sponsor.
I think this concludes our business for today, except Ms. Davis has got a little short video of the health retreat that we're going to watch here for a few minutes to give us a few highlights of what we missed out on by not being able to attend. But we were invited. Maybe some did, but it didn't fit in my schedule.
Could I make one
Yes,
announcement?
yes.
Anyone who has not submitted to their mandatory drug testing, the gentlemen are sitting back in the speaker's office, so you will need to do that here in the next few minutes.
Are we expected to need a meeting to do
No,
that? We can't do
when
it on
that's,
the break?
I'm hopeful that the next meeting will start just a little bit late. I think everybody's done it but two people.
So we're expected to leave the meeting to do it rather
I
than
said
wait to the break?
no.
Okay,
No.
I didn't hear you, I'm sorry.
Yeah, I'm sorry.
I wanted to clarify. Thank you.
Okay, Ms. Davis. We're ready here.
Can you dim the light?
We are trying to provide every service to our patient that they need. We don't want our patients having to travel to Tulsa or to Fort Smith to get specialty services that we need in our own communities.
I think we have an outstanding system from a quality perspective. We've grown in size and the services that we provide our population.
Cherokee Nation Health Services is a system of providers, a system of services that I just view as being much more comprehensive.
I was both a regional director for the Oklahoma area that oversaw Oklahoma, Kansas, and Texas. And then later in my career, I had an opportunity as a presidential appointee under President Bush to run the entire Indian Health Service. In that position, I had an opportunity to work with tribal leaders and tribal health systems all over the country. And from that experience, I can tell you that not only my opinion, but many people within the Department of Health and Human Services that traveled to Indian country with me when I was the director felt like the Cherokee Nation had an outstanding health system. Some very interesting thing that's happened to health lately has been involvement from our chief, Chief Baker, as well as the Tribal Council in making available to us, with the help of Cherokee Nation businesses. I should not forget to thank them because they are helping bring in these funds, $100 million in capital improvement dollars to our system.
I grew up in a place called Pensacola. People locally know that. And that's where my family lived, my grandparents lived just down the road from me. If I can't take care of my own family, my friends, and know within myself that they're getting the best I can possibly get, then I don't want to do it. And that's what drives me. I truly got committed to this community and the Cherokee Nation.
Always knew I was going to be a nurse. When I was a little girl, the Vietnam War was raging, and I remember seeing many things, people getting crippled. So I really wanted to become a nurse, a surgical nurse, sail around the world on the good ship Hope. And needless to say, I didn't make the good ship Hope, but I made it to some great operating rooms. So I've been with Hastings for about 10 years. This was my first experience, actually, dealing with someone sort of middle road, who was fighting for their life. Her car was on its top, leaning right against those trees. Those trees are what was holding her car from rolling down the hill. She was sitting up, and when I crawled through, I just began to tell her who I was and not to be afraid. But I did have to share with her the fact that her arm was gone. There was nothing we were going to be able to do about that, so I was honest with her from the beginning. So good to see you. Good to see you too. You look great. Thank you. I was really glad to see you. And you're used to your body being one way, and now it's changed. You can do a lot of things you probably just wouldn't be able to do.
Yeah, as soon as I got out of the hospital, I learned about my hands and everything, and just stuff like that.
You have changed my life. That 30 minutes of time that passed, I know it seemed very slow for you. It was pretty quick for me.
Yeah.
And things happened very quickly. But I just want you to know that my life has changed. I was supposed to come around that curve up and down. So we got it done. We're going to have a great life ahead. I know it. Without a doubt.
I was taking prescriptions for the osteoporosis. I had some setbacks that settled in my legs. I ended up with a cane. I couldn't even hold a can of green beans in my hand without it bothering me, which is hard to even imagine.
We try to do the best we can on the preventative side to keep them from going into the clinical side by helping some of the preventative measures with exercise and other health initiatives. And so we kind of use an exercise as medicine approach.
What Kim has done for me and with me has caused me to be able to apply all of this exercise to my everyday life.
My health is important to me. Your health is important to me. For all of us, for all our health, I choose Cherokee Nation.
I had a choice to work from any other hospitals in the area, but I chose Cherokee Nation Hastings Hospital.
We realize that our patients and our staff members have a choice, and we're glad that they choose Cherokee Nation.
At Cherokee Nation, we're all a family, and that's what makes us who we are.
At Cherokee Nation Health Services, our patients, our staff, we're all a family. At Cherokee Nation, we're all a family.
At Cherokee Nation, we're a family, and we try to work together for the betterment of the people.
We're just like friends, almost like family.
At Cherokee Nation, we're all family.
And getting popcorn fixed.
I'm glad you used Walking Sticks convertible in there. Had to put my hitch in
Thank you,
there.
Connie, that was great. We really enjoyed seeing the highlights. And we're just about ready to adjourn, but before we do, I would be remiss if I didn't mention Dr. Jones and the great tutorial report that he gave us to the council members and through an email on all the different types of dental crowns and the direction that our program is going. I told him a while ago, I understand what's in my mouth now. So he did a really great job, and he's doing a great job bringing in more money for us and getting better services out there to the people. So I think our health services are going in the right direction. Do I have a motion to adjourn?
So moved.
All in favor, let me know by saying aye. Aye. Okay. We are adjourned.